Good evening, doctors. Assalamu alaikum. Welcome to our 20th session of recall-based discussion. So here we have a list of topics which we are going to cover today. So let me take first topic, this one, solitary thyroid nodule. It's not very much in detail in MTB. So let me take you through AMBUS. So for thyroid nodules, see, thyroid nodules are abnormal growths within the thyroid gland. It may be one, that is called a solitary nodule, or it may be many, that may be a multinodular goiter. So they are present approximately 50% of general population, but only palpable in 5 to 10% of population. If it's a small nodule, so maybe you will miss on examination. You may not find any palpable nodule, but it's there. And they are saying it's only palpable in 5 to 10%, means remaining 90%, if it's there, it's not palpable at all because of a small size. And they are more common in women, especially in iodine deficient regions, and their incidence increases with age. So with the passage of time, the incidence is higher. Thyroid nodules are the clinical manifestation of various underlying thyroid diseases. So whenever the nodule is there, we can think about, it can present with the various underlying thyroid diseases. The majority of them are benign with colloid cysts, follicular adenomas, and Hashimoto thyroiditis. So we can think about here that if there is a solitary nodule, or if there is a nodule, mostly these nodules are benign, but it can present with the follicular adenomas as well. It can present with Hashimoto thyroiditis. This Hashimoto thyroiditis is one of a kind of hypothyroidism. We will see later. It's actually a presentation of hypothyroidism, but that may also lead to this solitary nodule. So being the most common causes, approximately 5% of thyroid nodules are malignant, with papillary carcinoma being the most common form of malignant disease. So it's not like that always you will find thyroid nodule as a benign condition. Maybe sometimes this thyroid nodules may present with papillary carcinoma. So papillary carcinoma, this is considered to be the most common form of most common form of malignant tumors of thyroid gland. We will see why it is called papillary, although this malignant tumor is actually the tumor of follicular cells, but because of the morphological appearance, it's just like, it's just present like a finger-like projection. So that's why it is called as a papillary carcinoma, although it's a carcinoma of the follicular cells of the thyroid gland, but its morphological appearance is just like a finger-shape appearance, papillary finger projection-like appearance. That's why it is named as papillary carcinoma. And please remember, for your exam point of view as well, this is the most common malignant form of thyroid tumors. Now, a thyroid incidentaloma is a nodule that is discovered during imaging from an unrelated cause and should be evaluated in the same way. So maybe incidental finding, you are doing a general examination, general physical examination, and on that you will get to know about this thyroid nodule. You can say it's incidentaloma, means incidental finding. You will just find during examination, the patient was totally asymptomatic. The initial evaluation of all thyroid nodules included TSH assay and thyroid ultrasound. So whenever there is a nodule, or whenever you will go for any diagnostic purpose for thyroid, nodule or thyroid palpable lump, you will always go for TSH. You will always perform TSH level, and you will always go for ultrasound in order to see. So those should be the best initial diagnostic measures. Now, sonographic signs of thyroid cancer should be further evaluated with fine needle aspiration cytology. So always remember, we have to go for the lab testing first. Like, we'll go for the TSH levels, then we will go for, especially this one, we'll go for ultrasound. When you find something on ultrasound, then you will proceed to fine needle aspiration cytology. Same thing happens in any kind of, when you are distinguishing between benign tumors and you are distinguishing between malignant tumors. There is particularly a study which is called as, we'll look for this study later, here, maybe down somewhere, that is called Thyroid Centigraphy. So this Thyroid Centigraphy also is the best initial modality. You will go for this one first, and then whatever the result, on the basis of that, you will go for FNAC. So never proceed for fine needle aspiration cytology at once. First, go through this scintigraphy, and whenever you will find any thyroid nodule, especially the solitary thyroid nodule, for your exam point of view, please memorize this thing, that for solitary nodule testing, diagnostic testing, we should always go for scintigraphy first, and based on the result of scintigraphy, we will proceed to FNAC. It's not like that we will always go for FNAC first. We have to go for scintigraphy examination, and then only we'll proceed to FNAC. So we will look on the basis of the findings of scintigraphy, whether it's a hot nodule or it's a cold nodule, and then we will decide we will go for FNAC. Now here the most common, if you're considering the hot nodule or the whatever this one, so it's saying the most common hot nodules are toxic adenomas. So whenever on the basis of scintigraphy result, find it's a hot nodule.
Your class started right now.
Alaikum, Dr. Tareen. Kindly put yourself on mute. If you want to ask anything, you can unmute yourself. Yeah. So the most common hot nodules are toxic adenomas and dominant nodules of toxic multinodular goiter. So whenever you do the scintigraphy and on the basis of scintigraphy, you find that nodule is a hot nodule, mostly those hot nodules are called as toxic adenomas and dominant nodules of toxic multinodular goiter. And sometimes they may present with multinodular pattern. They must not be a solitary, they must be a multinodular pattern. So think about this one, that what is the finding of the scintigraphy result? If scintigraphy is showing this, the hot nodule, we will always think about toxic adenomas. Now, if it's saying with a 5 to 15% risk of malignancy, cold nodules are clinically significant. Now, again, cold nodules, if you're considering, they are having a risk of malignancy. They can be a malignant one. Treatment depends on underlying etiology. Of course, whatever the etiology is there, if it's a malignant one, you have to go for the removal of that one. For sure, that is, you will go for thyroidectomy and autonomous nodule aspiration of thyroid cyst. If the cyst is there, we can just drain the cyst and we can just observe if there's a small nodule, it's a benign nodule. Maybe we will ask the patient for the follow-up and we will decide according to whatever the result of the follow-ups are there. So just think in the way that most of the time, 95% cases, solitary nodules are actually benign. But in 5% of cases, they may be malignant as well. And sometimes they may be solitary, like single nodule, and sometimes they be multinodular. Multinodular means multiple nodules may be there. Plus, very important point for our exam point of view, always remember, if you find any solitary nodule, you should always go for the scintigraphy. Scintigraphy is a technique where you just put the iodine and you will see the iodine uptake. If the iodine uptake is too much high, let me take you there so that you will have an idea. So we will see on the basis of scintigraphy result what is the type of nodule, whether it's a cold nodule or it's a hot nodule, based on this radio iodine uptake thing. So if we will see here, see a nuclear medicine test in which a radio tracer, usually radioactive iodine, is administered to a patient. The thyroid gland absorbs the tracer and the radiation is measured with an imaging device to create the picture of the gland. So actually we will see how the cells are going to take this radioactive iodine. So on the basis of that, we will say it's a cold nodule or it's a hot nodule. So if the radio iodine uptake is less, we will say it's a cold nodule. If the radio iodine uptake is high, we will say it's a hot nodule. So if it's a hot nodule, we have just learned this one. So if it's a hot nodule, you will always think about that it may be a toxic adenoma. Or if it's a cold nodule, we will think about that maybe in 5% of cases, it can be a malignant one. So only on the basis of scintigraphy findings, you will proceed to fine needle aspiration cytology. Never go for FNAC in the first attempt. Always, if there is a solitary nodule, you will go for the scintigraphy. Once the scintigraphy will give you a clue based on the radioactive iodine uptake. If the radioactive iodine uptake is high, you will say it's a hot nodule. Then only you will proceed to FNAC, like fine needle aspiration cytology, and thereby you will easily get a clue that whether it's a benign thing or it's a malignant thing. So you will decide the management, or later on maybe you should go for thyroidectomy, or what do you do? If it's a benign one, if it's a small one, benign one, maybe you should wait for some time, and then later on you will do the follow-up and do the treatment as per the follow-ups. So you should know what are the indications of this FNAC. What are the indications? So if there is a solid hypoechoic nodule which is more than 1 centimeter, which you have already diagnosed on scintigraphy, then you will go for FNAC. Maybe there are some extrathyroidal growth. Maybe some lymphadenopathies are there. There's cervical lymphadenopathy is there. That shows that metastasis is there, suggestive of distant metastasis, of course. So there are the conditions where we need to rule out whether the nodule, whether the lump in the thyroid is actually the malignant or a benign one. For that, we will go for FNAC. So let's have a look here, especially this one. So there are certain types. So here we are not bothered about all the types because we are only focused on the solitary nodule. So solitary nodule, we just did this one, that we will always rule out solitary nodule on the basis of scintigraphy. If scintigraphy result shows hot nodule or cold nodule, we will decide the management plan accordingly. And most of the time, thyroidectomy is the best option. So let's have a look at the question here. Here the question says, a 42-year-old woman presented with a 4-month history of an anterior neck swelling. So she's 42 years old and there is a history for 4 months history where she is having this anterior neck swelling. So swelling is appreciable. Physical examination confirmed a solitary nodule in the right lobe of thyroid. So you have already confirmed on the basis of physical examination that there is a big solitary nodule in the right lobe of the thyroid, and that is actually causing a anterior neck swelling. Now you have undergone the testing. You have undergone this thyroid stimulating hormone testing. See, TSH level is very low, 0.05, and thyroxine level is very high, 37. If normal is in between 8.5 to 15.2 micromole per milliliter, you will see the value 37, which is quite high. So T4 is very high, of course, and TSH is very low. So it's pointing you towards that this nodule is actually an adenoma. It's a tumor. So that's why the T4 is very high. Now, when you do the ultrasound, you will see right thyroid lobe solitary nodule 2 into 3 centimeters. So you, on the basis of ultrasound, you will easily get a clue. You remember, first we have to go for the lab testing. After lab testing, we'll go for the ultrasound. After ultrasound, we'll go for the scintigraphy. And after scintigraphy, we'll go for the FNAC. That should be the diagnostic protocol. Always starting with the lab investigation, you go for the TSH, you go for the T4 levels, then you do the ultrasound, then you do the scintigraphy, and then you do the FNAC. That should be the diagnostic protocol in terms of diagnosis of solitary nodule. Now, which of the following is the most appropriate next step? Now you have already done the ultrasound. What should be your next step? Your next step should be scintigraphy, and then after scintigraphy you will go for FNAC. Whenever there is a solitary thyroid nodule, you cannot go for FNAC directly. You have to confirm whether that solitary nodule, either it's a hot nodule or it's a cold nodule, so that you can easily go on scintigraphy, because if the radioactive iodine uptake is very high, we will say it's a hot nodule, and we have to think about toxic adenomas, and we must have to undergo for FNAC. But if the radioactive iodine uptake is low, it means it's a cold nodule, and most of the time those are benign, so you will have an idea, but it's still 5% there is a chance that it can be a malignant one. So always remember, first lab testing, then ultrasound, then scintigraphy, and then finally FNAC. Yes, Dr. Terry.
Nothing. I was repeating it to Dr. Hira. We are diagnosing here the anatomical condition, not the physiological, huh?
Yeah, because that's a obvious anterior neck swelling, and you have to go for the workup of that swelling. So of course, first the anatomical variation is there. Most of the time, these nodules are not palpable. But if this is the big enough, that's why it's obviously visible. And you have to go for the testing as well. Based on the lab investigation and based on the physical examination, it's a thyroid nodule. So anatomically, you have already proven. Then of course, it's causing a pathogenesis in the way. The patient must be symptomatic because TSH level is very low and T4 level is very high. So just think about all the features of hyperthyroid.
See, the TSH level is very low. And,
yeah.
TSH is low and 3-4 is high. It means it's a thyrotoxicosis.
Yeah. So, but see, thyrotoxicosis is a condition in which T4 level is very, very high. Very high, and the patient must be presenting with the thyroid storm, the physical. But here there is no presentation related to the thyroid storm. The patient is symptomatic, less symptomatic. The symptoms are not mentioned here at all, so you cannot make a diagnosis of thyrotoxicosis.
Symptoms are not given in this question.
Yeah. Okay. Yes. So based on the presentation, based on the symptoms, we usually make the diagnosis of thyrotoxicosis because that is a thyroid storm, very much high levels of T4. Yes. Okay. So for the next question, we have to go for the theory first. Next, we have this papillary thyroid cancer. Again, it's not there in MTB. So I will take you to AMBUS. Okay. For this papillary thyroid cancer carcinoma, always remember that this is one of the most common presentation of thyroid carcinoma, most common presentation. And why it is called papillary? Although it's a tumor which is going to arise from the follicular cells of thyroid gland. So follicular cells, if there is too much growth of the follicular cells of thyroid, that is actually the reason for this papillary thyroid carcinoma. But why we are saying it's papillary? Because of its morphological appearance. Its morphological appearance is finger-like projection. That's why it is known as papillary. And one very important distinguishing factor in between the papillary thyroid carcinoma and the follicular thyroid carcinoma, that follicular thyroid carcinoma usually you will see that they are not going to metastasize into the lymph nodes. They are usually in the thyroid gland. But in case of papillary thyroid, you will always find the metastasis. There will always be a metastasis to regional lymph nodes. So you will find cervical lymph nodes may be enlarged here. So always remember this papillary thyroid carcinoma, although it's a carcinoma, although you will see it's a tumor of follicular cells, but these follicular cells are going to metastasize into the regional lymph nodes, the localized lymph nodes, and can cause lymphadenopathy. But in case of follicular carcinoma, of course, there is again a follicular tumor, but follicular cell tumor, but that is going to be restricted into the thyroid gland. You will not find any kind of metastasis. That's the only thing. And most of the time, in 90 to 95% cases, whatever the carcinoma is there, on histopathology, it will usually be a papillary thyroid cancer. So it's very common. So we will see here, especially if you're considering this papillary thyroid carcinoma. So thyrocytes, these are the follicular cells of the thyroid gland. So they can give rise to papillary thyroid carcinoma based on the morphological appearance, like the carcinoma is just like finger-like projection. Follicular thyroid carcinoma based on the name of the follicular cell, and anaplastic means you cannot easily differentiate the cells. So if the cells are morphologically so much different, so much variations in the morphology of the cells, we can say it's anaplasia. Now, this one, papillary thyroid, it's a most common type of thyroid cancer. Palpable lymph. Yes, dear.
So, what is the difference between papillary and follicular thyroid carcinomas?
If you're asking me the origin of the cell, then origin of the cell is the same one. Follicular also arises from the follicular cells, and papillary also arises from the follicular cells. But papillary has a finger-like projection appearance, and metastasis is always there. And then you can say it's a papillary one. Follicular cells, it can be round, it can be of any shape, but it's not a particular finger-like projection, and it's not going to metastasize. You will not see any kind of follicular cells in lymph nodes. So you will say it's a follicular. It will remain intact into the follicular area of the thyroid gland. So that is the main difference between papillary and follicular. Papillary is a finger-like projection. You will find them into the lymph nodes as well, because cells are going to metastasize. They will go and get trapped into the lymph node, these cells, tumor cells. But in follicular cells, of course, these are the follicular cell tumors, but they are not going to metastasize, and their shape also is not a finger-like projection. It can be of any shape. Mostly they are round and globular. That's
so
what.
where will be these finger-like projections? Inside the thyroid, where the
yeah, once you cut the tumor on histopathology, you will see all finger-like projections like villi, like finger-like projection. That's why it's called papillary. It's just based on the histopathology. Let me show you the diagram. The diagram is here. See? So once you do the histopathology, you will see all these finger-like papilla projections. So based on this morphology, you can say it's a papillary tumor, only based on the morphology.
Okay, morphologically,
morphologically.
Can you please show us follicular thyroid too?
Follicular thyroid carcinoma. Okay, you want to see the histopathology? Let me show you.
Papillary, follicular, gastric, and
See, mostly these are follicles, big round follicles. Can you appreciate this one? They are not like papilla-like. They are just round follicles will be there. Too much round follicles because it's a tumor.
Yes.
Excessive growth.
Okay. Okay, so this is a histological difference. This is a follicle and papillary. Papillary will metastasize. Okay. If it will not metastasize.
Okay. So now what they're saying, if there's a papillary thyroid cancer, very good prognosis is there. You can easily cure this one. And 32 most peak incidence, like the patient who's presenting to you, who's having this papillary thyroid cancer, maybe in ages between 30 to 50 years of age. So in adolescent age, you can easily find this papillary thyroid. But if you are considering follicular thyroid cancer, we may find in 40 to 60 years of age. So there are some age differences. Again, age differences are not very hard and fast, but majority will present like this. Distribution, you will see most common, you will find mostly 80% of cases the patient usually present with parathyroid cancer, and if you will find follicular cells, so only 10% cases you will find as follicular cells. So most common presentation is papillary thyroid, but still there are chances of follicular, and how you're going to set a follicular one, you will see the follicles on histopathology, and of course there will be no metastasis, especially on this one. So what we will do on how we are going to see clinical features, any kind of carcinoma, whether it's a papillary one, whether it's a follicular one, the presentation can be anything. There may be a nodule, there may be, of course, if there is a nodule, you will go for the you already did this one. If it's there a nodule, how we'll proceed with this one? We'll go for the lab testing, we'll go for the ultrasound, we'll go for the scintigraphy, and then we will go for the FNAC. So same protocol you're going to follow here. There is no much changes in the protocol, following the protocol. Clinical features, of course, what are the normal clinical features? Whoever is presenting with carcinoma of thyroid gland, whatever kind of carcinoma, follicular, papillary, anaplasia, whatever, there must be a hoarseness of voice, there must be difficulty.
Dr. Hira, sorry, there was also medullary.
Yeah, medullary also. But here we are, there are many, that's a parafollicular cells. If you are considering only follicular cells, that has only 3 variants: papillary, follicular, and anaplasia. They are all coming from only one cell type, that is a follicular cell. But if it's a parafollicular, means those cells which are in between 2 follicles, those are called parafollicular. Then carcinoma is called medullary carcinoma. So here we are only discussing about papillary one, so I'm just focusing on that one. But you should remember there are 2 cells in the thyroid gland. One is follicular cells and one are parafollicular cells. So if there is a tumor of follicular cells, it has 3 presentation. It may be a papillary one, it may be a follicular one, or it may be an anaplastic one. Or if there is a tumor of parafollicular cells, we can say it's a medullary carcinoma. Okay, so here, because the main topic for our discussion is papillary, so I'm just emphasizing on papillary, but you should know, of course, all these.
Why are we not doing this one? We should complete all this topic now.
No, dear. Why you're forgetting all the time? We are here only for the recall-based discussion. We are not here covering the whole theory. There may be separate classes for that one. If you really want, you can join those classes. Okay. But here we are only focused on the recalls. Whatever the recalls we have, we are doing the theory of only those recalls. Otherwise, it will be a C. You know, we
are not completing all the. You are not teaching us, preparing us properly for the exam. Okay.
Yeah, because my main focus is only to make you understand the recalls, the recent recalls, the theory of the recent recall, so that you have a clear clue that what should be the answer. With the help of these broken recalls, at least you should be able to pick the right answer. That is my main motive for these sessions. Yes. Okay. So let's cover up this topic first. So here you will see the clinical features. So whoever the carcinoma is there, maybe it's a papillary one, maybe it's a follicular one or parafollicular, whichever is there, the presentation should almost be the same. Of course, on the basis of histopathology, you are going to differentiate, but symptomatic, if you are considered about the symptoms, that should almost be the same. Say, for example, the patient may present with the hoarseness of voice, the patient may present with a difficulty in breathing, the patient may present with difficulty in swallowing, that is dysphagia. So these are all the presentation which you can see everywhere. So of course, only basis on the symptoms, you cannot say this is this type of carcinoma. Of course, you cannot say. Based on the histopathology, based on the lab investigation, based on the result of FNAC, then only you will be so sure, okay, this is follicular, this is medullary, this is anaplastic, and whatever. So based on the symptoms, you cannot say, because symptoms are usually the same in every kind of carcinoma, especially thyroid carcinoma. The Patient may present with lymphadenopathy, but you know very well, whenever lymphadenopathy is there, lymph nodes are enlarged, then always think about papillary one, because papillary is the one which has the high power of metastasis rather than any kind of other thyroid one. Okay. So not only this one, now, what are the signs of distant metastasis? Distant metastasis means that you're not going to find this tumor cells in the thyroid gland, but also in the other part of the body, not only maybe in the lymph nodes. Say, for example, if they're going to enter into the lungs, then what will happen? They will cause pulmonary metastasis, and pulmonary metastasis, the patient may present with coughing, hemoptysis, and dyspnea. If these tumor cells are going to go into the bones, you will find some bone pathologies, the bone metastasis may be there. And they can also metastasize into brain, because malignant cells, they have the power of metastasis. They can go into the distant sites. So most of the time, especially this papillary thyroid cancer, if you are considering thyroid cancers, if you are considering, it may metastasize into the lungs, it may metastasize into the bones, and it may metastasize into the brain as well. So these are the three things. So if it metastasizes into the brain, you may find some seizures or focal neurological deficits, of course. Now, for the diagnostic point of view, let me show you this one. So, of course, whenever there is a carcinoma, the patient is presenting with the nodule, but on investigation, you will find whether it's a solitary nodule, or whether it's a carcinoma, or it's a papillary carcinoma, or it's a follicular carcinoma, or it's a medullary carcinoma. So always, when there is a nodule, when there is a suspicious of something, you will go for history and physical examination. You will go for the lab investigation first. We have already covered this one. You should do TSH testing. You should do T4 levels. You should go for the ultrasound. On ultrasound, if you find anything, of course, you will go for scintigraphy in order to see if there is a nodule, whether it's a hot nodule or it's a cold nodule, and if you find anything on that, then you will proceed to FNAC. You will go for FNAC, and on the basis of FNAC and cytology, you will exactly have an idea that what kind of tumor it is. So that is the same repetition of this one. We have already covered this one. So now here, if you are considering again follicular papillary thyroid cancer, there are some additional studies. So additional studies means that, especially if you have already confirmed that this may be a follicular one, or this may be a papillary thyroid one, you can also go for some antibodies testing as well. Say, for example, here we have thyroglobulin antibodies. These are the precursor of thyroid hormones produced exclusively by the thyroid gland. So indicated after total thyroidectomy or this one. So why we are concerned about this thyroid cancer tumor markers? These are called thyroid cancer tumor markers. That will give you a clue, because if there are too much levels of thyroglobulin, the patient may have some recurrent problems. So then you have to decide, we should give some antigen antibody reaction. We should give some medicines that will act on thyroglobulin, and that will decrease the functioning of this thyroglobulin. So we have to go for some other additional studies in order to see what exactly the reason. Maybe sometimes these antibodies levels are too much high, so that what will happen, that antigen antibody reaction occurs in our body, and that will cause autoimmune thyroid cancers. So we should also look for these ones. Sometimes we have say they are saying calcitonin, a hormone secreted by parafollicular cell, which is the tissue of origin of medullary carcinoma. So this is especially for medullary carcinoma. You should check the level of calcitonin. You should go for this carcinoembryonic antigen, because whenever there is a tumor, we will always have some tumor markers in the body, which will give us a clue, like this is the increased amount of CEA in the body. So maybe you should confirm that, okay, it's a medullary carcinoma, because in medullary carcinoma there is always increased amount of carcinoembryonic antigen. In thyroid, if the thyroglobulin is too much increased, it will give you a clue, okay, it's a follicular carcinoma. So that is an additional studies which will help you in order to make a definitive diagnosis. For the staging point of view, staging include evaluation of cervical lymph node. You have to, for the staging always, we should see like what kind of lymph nodes are involved, how many lymph nodes are involved, what other distant metastatic sites are involved. Only on the basis of that, we will say these are the stages. So say, for example, we have, if you want to see whether it's a pulmonary metastasis or not, you will go for the chest X-ray and the CT scan. Maybe you will find mass there. If it's a bone metastasis, you will go for bone scintigraphy. If it's If you are considering about the brain metastasis, you will go for the CT and MRI of the head in order to rule out whether there is bony metastasis or not. So for the treatment point of view, if you have already understood, okay, this is a thyroid cancer, and whatever the kind is there. So for example, if you come to know, okay, it's a papillary one. So if it's a papillary one, what we usually do, we'll go for thyroidectomy. So standard management should be total thyroidectomy. Whenever you will find any kind of carcinoma, because it is a carcinoma, it is a malignant one, your protocol, your standard protocol should be total thyroidectomy. That's the gold standard, with neck dissection as needed. And we will go for radiotherapy, and we'll go for the chemotherapy option. But if there are small cancers without nodal or distant metastasis, maybe you should consider about removing that portion where only the tumor is there, if there is no metastasis. But of course, if there is metastasis, we'll have to go for total thyroidectomy. And of course, we will go for suppression therapy. They are saying if there is papillary microcarcinoma, we'll consider only active surveillance. We will not do anything. We'll just go for the supportive treatment and we will do that follow-up. But if it's poorly differentiated cancer, say for example, too much metastasis is there, you have to go for total thyroidectomy. You have to put your patient on chemotherapy. Maybe radiotherapy can also be, you need to initiate radiotherapy as well. And if it's an anaplastic one, again, total thyroidectomy. So just for exam point of view, just memorize this one. Whenever there is carcinoma, your standard management, your standard treatment should be total thyroidectomy. If it's a small one, metastasis is not there, maybe you should go for removal of that area only where the tumor is. Maybe that is hemithyroidectomy, but it is always a good choice to remove the whole gland because it is a malignant tumor. It is a carcinoma. That is the important thing. So they have mentioned all total thyroidectomy indications as well. You can go through by yourself, but it's mainly this one. So let's have a look at the question here. Here the question says, a 33-year-old woman presented with a lump in her neck. So here again, the age of the patient is 33 years. So you should, if you could memorize, if you could recall the ages, if it's in between 30 to 50 years, the papillary chances are high. If it's in between 40 to 60 years, the follicular chances are high, follicular carcinoma. So a 33-year-old woman presented with lump in her neck, physical examination confirmed enlarged right cervical lymph node. So her age is 33. She is having a lump in her neck, and not only the lump, she is also having this cervical lymph node which is enlarged. So now could you recall, whenever there is enlargement of the cervical lymph node, regional lymph node is enlarged, lump is there, it means that it must be a papillary one, because papillary one is the most common in this age, especially 30 to 50 years. Plus papillary is the one which is only metastasizing to regional lymph nodes with the normal thyroid gland. Now, she underwent percutaneous biopsy of the lymph node. So biopsy of the lymph node you have performed, and histopathology reveals normal follicular thyroid cells. So it means that you have already seen the other follicular cells which are absolutely normal here, whichever is the most likely diagnosis. So what do you think that can be here? If normal follicular thyroid cells on histopathology, like follicles are normal, but if especially you're getting this point, follicular cells in which we are considering about the follicular carcinoma, that is showing the normal one, but still you have this tumor, it means that it must be presenting. If they have mentioned papillary projection or finger-like projection, so it will definitely give you a clue, but it's okay anyhow. Based on the answer choices, we can rule out. Ectopic thyroid means that other than the thyroid, if this nodule is inside the neck, so of course this option is excluded. Thyroid lymphoma is actually the lymphoma where we see lymph node enlargement. So for that one, there has to be a follicular thyroid. You must have find the pathology in the thyroid follicles. So if it's not there, you cannot say it's a thyroid lymphoma. So this also is excluded. And then papillary thyroid cancer, this is the most likely one. And follicular thyroid cancer, if normal follicular cells, of course, this follicular thyroid cancer is excluded. So we have only this option left, and based on the age of the patient, based on the presentation, like lump in the neck, based on the presentation, like metastasis is there, and so we will easily say it's a papillary thyroid cancer.
Excuse me, Dr. Hira.
Yes.
Can you little explain again why not ectopic thyroid with this?
Ectopic thyroid means that you will find thyroid tissues other than the thyroid, like
Yes.
thyroid follicles other than the thyroid. So here there is no here lump in her neck. Maybe if you find any kind of lump in the brain, of course not a lump, but if there is a lesion in the brain that needs to be
it's
resolved.
clear. Why they're saying histologically normal follicular thyroid cells?
Because maybe because it's a recall,
If it's a papillary thyroid carcinoma, then the papillary cells will be there in the gland, in the lymph node.
Actually, this girl, she wouldn't be able to recall the proper thing, but she had mentioned me that something follicular cells were normal. So it will give me a clue that follicular cells normal means that you will not find multiple follicles. So follicular carcinoma must be excluded. Because whenever it's a normal follicular thyroid cell, it means that whatever the follicular cells are there, the number was okay, right? That there should not be a tumor of that follicular cells in order to make a diagnosis of follicular thyroid cancer. But of course, if the diagram is there, then you can easily differentiate the finger-like projections and you can say, okay, it's a papillary thyroid. Why papillary thyroid? Because you will not find follicles there. Round follicles you will not see. You will find only the finger-like projection. So most of the time, these questions will always have a histopathological image. So you will always find a histopathology image there. So you can easily relate. If you find too many follicles, too much follicles in the same presentation, you will go for the follicular carcinoma. But if you will find follicles are not very much,
but
2, 3, 4, 5,
what does this mean? Normal follicular thyroid cells.
Normal follicular thyroid cell means that whatever
the thyroid cells have metastasized into the lymph node, but they are normal follicular cells.
Yeah, the presentation is normal. So it means that the follicular cells, like their morphology is normal. So you will find small round follicular cells, normal one. But of course, if we are considering papillary one, they must have transformed morphologically and you will find finger-like projections other than the follicles. So you will find follicles normally. Yes, dear.
So
the question as well says with a normal thyroid gland in the second line. So it's kind of confusing. What could be the scenario if it was not a recall? Can you just explain that?
Yeah, but it's not properly formed recall. But normally, if there is a lump in the neck, so you will always consider, and if this lump is palpable, so there must be something inside. But once it's mentioned normal thyroid gland, like we have seen this normal appearance, although lump is there, but once you check the thyroid gland, you will not find any abnormality rather than just the collection of a cell there, and those cells are apparently normal. So it's okay, morphology is okay because we have
excuse me, because these are thyroid cells in the lymph node, that means it's a carcinoma.
Yes, because metastasis is there. Metastasis is there, and based on the metastatic finding, we can say, okay, these are thyroid follicles.
Because most of the time, papillary thyroid carcinoma metastasis, so it is
metastasis. Yes, and for the other doctor who has a question, see, the third variant is anaplastic one. So we will always see for the some ill morphological cells, like those who are presenting ill, those who are presenting abnormal cells. That's called anaplastic cell. So in thyroid, we do have carcinoma where some anaphylactic cells, this anaplastic cells are also there. So you cannot easily relate, oh, what are these kinds of cells? But actually, those are follicular cells which have now changed into anaplastic cells. So that's why they must have mentioned something like this, so that you cannot confuse with the anaplastic type, or you cannot imagine, okay, there may be some anaplastic cell. That's why this patient is having lump in the neck, but it's clearly showing that the thyroid gland cells and everything is normal, but only the point is the total number is increased. That's why the patient is having lump. Are you getting my point?
Yes.
That is the thing. Morphologically, they are giving you a clue so that you can easily pick, okay, morphologically is normal. So it means that if morphology is normal but increase in amount and metastasis is there, so I should always consider papillary.
But Dr. Hira, here is the lump is the lump
in her neck.
The lump with the patient presented was the cervical lymph node. It was not the thyroid enlargement.
Oh dear, lump in the neck is there. But also there is a confirmed enlarged cervical lymph node. So you will all, of course, it's not like that you palpate the thyroid gland and thyroid gland is normal and you are saying, okay, that lump is actually the cervical lymph node. It must be presentation like that as well. When you
So
only
there are
find the
two
thyroid
lumps.
gland,
One is in the, okay, one lump given is in the neck, and the
Yes.
examination we found in the
yes,
cervical lymph nodes.
because that lump should be visible. And when you check the lymph node, cervical lymph node, that is also, you will see that's an enlarged one, only the right side one. So that will give you a clue.
Yeah, this is very incomplete and confusing
Yeah,
question.
yeah. But at least you should read the whole topic so that you have clear mind, clear in this in your mind, that whenever there is a papillary thing, you will find nodule in the thyroid. Once you check the morphology, that would be absolutely normal follicular cells, but you will find finger-like projections. Based on that, you will say it's a papillary one. When you do the histopathology, when you do the FNAC, then only you will say. And importantly, when once you do the tumor this marker, especially T3 and TSH, you will see TSH low, you will see T4 high. Then only you will go for further thing and you will see the patient symptoms. So symptoms are not very much. So it means that there is no storm and everything in there. You can easily exclude the hyperparathyroidism symptoms in there in that patient. Then only you will say, okay, if this swelling is not painful, then again it will give you a clue. If metastasis is there, it will again give you a clue of papillary thyroid. So just read the important this papillary and follicular cells. At least you should know that what are the distinguishing factors so that you can easily differentiate. And based on the answer choices, you can easily say, yeah, this is a papillary thyroid cancer. If it's a follicular one, then you will find increased number of follicular cells and there will be no lymph node palpable. There will be no metastasis of the lymph node. Then you can say it's a follicular. If it's a solitary nodule, so you will find only one nodule. Once you do the examination, you will get to know, okay, it's a solitary nodule, hot nodule, or a cold nodule, or whatever is there. Let's go to the next one. And for the next one, we have to go
Thank you
for
very much for the explanation.
So for the next one, we have to go for the theory first. We go for acute pancreatitis. This we can cover from MTB. Okay, for acute pancreatitis, of course, as the word indicates, itis, so it's inflammation. It's an acute inflammation of the pancreas with over 90% caused by. So most of the time, whenever there are stones in the gallbladder, that can cause inflammation in the pancreas, or whenever the patient is alcoholic. So these are the two basic etiologies. You will always look for these two conditions in your answer choices, whenever the patient is having any history of stones in the gallbladder and long-standing stones. For the long period of time, the stones are there, and that can irritate the pancreas, and that can cause inflammation of the pancreas. And if the patient is alcoholic, these are the two basic strong associations. So pancreatitis, a stone, a stricture, a tumor, and obstruction. So there may be anything. If there is obstruction in the bile duct, if there is a stricture in the pancreas, if there is a stone in the bile duct, if there is a stone in the gallbladder, or if there is any tumor especially around there, say for example pancreatic head tumor, that can all lead to pancreatitis. So for making a diagnosis of pancreatitis, there are so many etiological factors, there are so many causative agents that can lead to pancreatitis. Less common causes other than that, maybe a trauma history is there that can lead to inflammation of the pancreas. Sometimes there are high triglyceridemia levels, increased triglyceride level in the blood. That can also lead to pancreas inflammation. There is hypercalcemia. There is too much amount of calcium in the blood. That can also stimulate and can cause the pancreatitis. But these are very less common. You can never ever imagine these things in order to make a diagnosis of pancreatitis. Some drug interaction, some drug toxicity, you can see drug allergies are there, ductal obstruction is there, some scorpion sting, some bites, insect bites are there, that can lead to pancreatitis. But the two most common one which you are not going to forget, those two are, the first one is alcoholic history, and the second one is cholelithiasis. If there are stones in the gallbladder, that mostly ended up in pancreatitis, or may cause the inflammation of the pancreas. So how the patient is going to present to you, if the patient is having acute pancreatitis or the patient is having pancreatitis, there must be an acute epigastric pain, sudden epigastric pain. There will be sudden tenderness in the epigastric area. That is followed by nausea and vomiting. So if the patient is having severe epigastric pain, suddenly started, there was no association before, and suddenly the patient is experiencing this nausea and vomiting, you can think about pancreatitis. In severe cases, there is hypertension and fever as well. Of course, whenever there is inflammation, you will always find rubella, calipella, all the signs of inflammation you can find in your patient, and the patient may present with hypertension as well. So these are, but in severe cases, not all the time. So all the time, mostly the presentation is epigastric pain, tenderness is there, and the patient can be having nausea and vomiting. So for the diagnostic point of view, what we will do, we will check the best initial test. Of course, we know very well pancreas has to release this amylase and lipase. So the best initial test, we will always go and check for these amylase and lipase. And the most specific test where we can exactly see whether there is what is exact cause of this one, we'll go for the CT scan. So maybe on CT scan, you will find tumor of the pancreas. That is the main cause. Maybe on the CT scan, you will find stones in the gallbladder or stones in the bile duct or whatever is there, you can easily locate on CT scan. So disease severity is strongly correlated with the degree of necrosis seen on the CT. Of course, everything on the basis of CT scan, you can easily. Needle biopsy is indispensable in determining the presence of infection in those who have extensive necrosis. If necrosis is there, we know very well that necrosis should not happen in just in a jiffy. It will take some time. First of all, there will be inflammation, then there will be ischemia of that area, then ischemia first is reversible ischemia, then it will become irreversible ischemia, and then it will lead to necrosis, or plus if an infection is there, that can also lead to gangrenous state of that state. So here they are saying greater than 30% necrosis is extensive necrosis. So extensive necrosis means that whenever the term says extensive necrosis, always think about that 30% area is necrosed. 30% area is now getting into that state from where it cannot be reversed because of ischemia, because of infection, because of inflammation. So that is called extensive necrosis. So here, if you do the CBC count, you will do the lab test, you will do the CBC count. Of course, if there is inflammation, you will find this glycocytosis, WBCs will be increased, and drop in hematocrit over time with rehydration. So once you rehydrate the patient, you will find hematocrit will be decreased, because hematocrit is the overall number of cells in the plasma. But once we hydrate the patient, the liquid portion will get higher as compared to the solid portion, and that's why we will see decrease in hematocrit. Elevated LDH and AST. So of course that is as a feedback, as a negative feedback, you will see this, especially this lactate dehydrogenase and this AST hormone, they are going to be increased you will see the increase amount, but most of the time we usually don't prefer this lactate dehydrogenase and AST. We usually go for the amylase and lipase testing. But in combination, if you do this lactate dehydrogenase and if you see it's high, it will give you a clue, okay, simultaneously the feedback mechanism is going on in the body, and as a compensatory effect, you will find elevated dehydrogenase. There may be, we will find hypoxia, low oxygen, hypocalcemia, elevated urinary trypsinogen activation peptide. See, this trypsinogen activation peptide you will find in the urine. It's not going to act on the pancreas. Why? The pancreatic cells are not working fine, functionally they are not doing their job. That's why this trypsinogen is excreted just into the urine. The same way it's formed, the same way it's excreted in the urine, because the pancreatic cells are not actually functional. So that's why this trypsinogen activated protein is not going to active on the pancreatic cells. Although the trypsinogen has to act on trypsinogen, peptide has to act on trypsinogen and convert the trypsinogen into trypsin. And trypsin is the one who will do the protein digestion. That's an important enzyme who will participate in digestion of protein. But this is actually just releasing in the urine like the way it's formed. Why? Because pancreatic cells are not functional here. For the imaging point of view, we'll go for the...
LDH and AST will be elevated, and what about lipase and amylase?
Lipase and amylase will always be increased. You will find increase. That's the best initial test. We have to perform amylase and lipase. These are some extra additional lab tests which you can perform that can help in making a diagnosis. But of course, we have to go for the initial test are amylase and lipase. You will always find them high. Okay. That's the important thing. Yeah. That's the best initial test. Here they have mentioned already, and these are the further lab testing which will help.
Why they will be hypocalcemia? What is the pathophysiology?
See, hypocalcemia, first of all, you just remember this one, that whenever we are considering this pancreatic enzymes and pancreatic and the hormones which are actually act on pancreas in order to release the pancreatic enzymes, those are the main, you can say, they need something for the contraction. Otherwise, the pancreas cannot be contracted and cannot release these hormones. So if pancreas is not working fine, or maybe you will find low calcium level, so you can think about that contractility of the pancreas is, it will not be functional, like will not be very much appreciated because of the low level of calcium. Because calcium is the one, always, whenever there is a contraction of anything, always think about calcium. So whenever we are considering that calcium levels are low, that will actually, what it will do, you can imagine that pancreatic cells are not getting contracted and they are not releasing enzymes, owing to the effect that calcium is overall low in blood. And why is calcium is overall low in blood? That is again a separate thing. There may be any other reason as well, because of that calcium is low. But here, if you are finding concomitant decrease in calcium, it will give you a clue that whatever the pancreatic cells are there, they are not actually contracting, they are not actually releasing enzymes. So that's why that is actually because of hypocalcemia. So here, the pancreatic insufficiency is not leading to hypocalcemia. Hypocalcemia is the one other way around. You can say that that is not going to do much function, or you can say because of the low level of calcium, whatever the remaining pancreatic cells are there, which are still in the phase that they can contract and they can release the hormones and enzymes, but they are not doing so. Why? Because of the deficiency of calcium. So that is the other thing. So most of the time, whenever you find this thing, you will always find low levels of calcium. So that you can easily relate. So that is only for the relative finding you can easily find in those patients. But it's not like that because of the pancreatitis or because of the insufficiency of the pancreas, you're finding it hypocalcemia. No, hypocalcemia is the one which will exaggerate the condition of pancreatitis. Because once it is less in number, it cannot contract even the normal cells of the pancreas and cannot release the enzymes. So that is other way around. So in combination, you can find hypocalcemia. It's not because of this one. Okay. Now here for imaging studies, you will go for the CT MRI. You will exactly see what is the cause behind this inflammation and everything. MRCP is useful in determining the etiology of the disease. Say for example, stones are there, strictures are there. So you can go for especially this magnetic resonance, this cholangiopancreatography. That is an imaging technique by which you can easily see the stones and structures and all that. Plain X-ray can also help. Sometimes plain X-ray you will see air-filled piece of small bowel in the left upper quadrant. That may be the reason where we can see sentinel loop of the bowel is there. That can cause something resistance to the pancreas, or that can show some resistance to the pancreas, and that's why the pancreatic cells become irritable and cause inflammation. So that may be one of the reasons, but not all of the time you will see like this. Ultrasound has very poor accuracy overlying bowel blocks. Precise imaging, ultrasound will not give you much clue. So always remember, we have to go for either we can do the lab testing, or we have to go for the most accurate test, that is CT or MRI. So abdominal CT is the highly preferable one, and we should always go for the contrast one in order to see the abdominal structures. So we'll always go for that one. Now for the treatment point of view, what we will do, we'll ask the patient not to pick anything for now. So we'll keep the patient and PO, nothing for oral. We'll hydrate the patients. We'll give them analgesia if there is too much pain. We can give him this proton pump inhibitors, decrease pancreatic stimulation from acid entering the duodenum. So if you give the PPI, so that will help the pancreas not to work. Why? Because if there's still some of the pancreas is working, it will release enzymes that can do the digestion. But we don't want pancreas to be stressed right now, because the pancreas is already in so much stress. So we'll give proton pump inhibitors. If there is more than 30% necrosis on CT and MRI, adding antibiotics such as imipenem or meropenem. So we can give antibiotic as well, because leukocytosis is there. So we can give antibiotic in order to stop the progression of the disease. Whatever the damage is there. You cannot reverse the damage, but at least you can stop the progression of the disease. So severe necrosis is an indication for needle biopsy to determine the presence of infection. The only way to confirm the infection, of course, the only way will always be the biopsy. So after CT scan, you can go for biopsy as well. Now, if there is infected necrotic pancreatitis, should be resected with surgical debridement. Of course, if there is too much necrosis, you have to remove that area. You have no other option. So you will go for surgical debridement of that area to prevent, the patient getting into the ARDS or getting into the death, of course, because necrosis is very dangerous thing. Necrosis you cannot reverse in any way. That portion has to be debride. Okay. So this is one of the complication of pancreas. Most of the time, the pancreas may present with pseudocyst as well. That should be drained with the needle if they are enlarging or painful. So, but that has nothing to do with the pancreatitis, because once the acute pancreatitis is there, you may not appreciate pseudocyst. But if only there is isolated pseudocyst which is actually causing the infection or inflammation, that can also be the reason. And in that, we can only drain this cyst. We will not go for the debridement of anything. We will just drain this cyst and we will give antibiotic. So now let's have a look at the questions here. Here the question says, a 45-year-old woman present to the emergency department with severe continuous mid-abdominal pain for 16 hours. Now it's a very layman term, mid-abdomen. Of course, if we are considering mid-abdomen, what exactly the region should it be? It may be epigastric region, it may be the upper quadrant. What quadrant is that? But anyhow, it's a vague terminology by saying just the mid-abdominal. Normally, mid-abdominal, we are referring to epigastric area. For 16 hours. Now, associated with nausea, vomiting. So, she is having this severe continuous pain. She is having this nausea, vomiting. She is known to have cholelithiasis. Now, this patient has already have this history of stones in the gallbladder, but must be asymptomatic. But right now, just suddenly, started sudden. There's sudden pain and sudden nausea, vomiting, and she has a history of cholelithiasis. These findings are very much suggestive of pancreatitis and being in the epigastric area. Physical examination confirm epigastric tenderness. Now that is the patient is saying mid-abdominal. Once you do the physical examination, you can appreciate there is epigastric tenderness. Now it should come in your mind that, okay, cholelithiasis history is there, sudden onset is there. It means that it must be a pancreatitis. Your provisional diagnosis should always be a pancreatitis. Then test result, normal values, WBC, you will see. Test result showed WBC 13, so it's leukocytosis. Amylase 650, so amylase is high. So amylase and lipase are the best indicators if the patient present with these severe epigastric pain, sudden onset, there is a history of cholelithiasis. You can easily relate with the lab result as well. WBCs are high, amylase level is high. If there are more levels, say for example, LDH is there, lipase is there, calcium levels are there, that should be low. So you can always relate to all these levels that this is a case of pancreatitis. So why we are not saying it's hepatitis? Of course, for hepatitis, the patient's presentation should be a jaundice one, right? It always should be started with a jaundice. So it can easily be excluded out. Acute cholecystitis. For acute cholecystitis, the patient must present with this one, but you will not find increased level of amylase and all that. You will find bilirubin level should be high in that case if there is acute cholecystitis. So you can also rule out this one. Perforated peptic ulcer, again, it has nothing to do with the amylase level. The presentation can be like this one, epigastric pain, but you will not find high level of amylase. And for perforated peptic ulcer, why they should have given you the history of cholelithiasis? It has nothing to do with the peptic ulcer. So that's a clear case of acute pancreatitis. Now this question, a 45-year-old patient complains of recurrent episode of upper abdominal pain for the past 2 weeks with fever. Now he has upper abdominal pain for the past 2 weeks and fever is also there. Think about fever. Sometimes patient may present with the fever as well. On examination, the patient is jaundiced. Abdomen is sought with marked tenderness all over the abdomen. Now this patient is showing the signs of obstruction. So that's why he is jaundiced and overall tenderness is there in the abdomen. Blood pressure is 98/60. Blood pressure is low. Heart rate is high. Respiratory rate is okay. Temperature is high because he's having fever. Test values, just have a look at this test value. Indirect bili is 5. So it's not very much high. Direct bili is 20. So direct bilirubin is high, but indirect is low. Total bili, overall, if you can see, the bilirubin levels are high. Alkaline phosphatase high, amylase levels are too much high, 1400. There is too much value of this amylase level. Now, when you do the ultrasound, you have seen this common bile duct, which is having a thickness of 1.4 centimeter with dilatation of intrahepatic ducts. So there is dilatation of the common bile duct. Which of the following is the most likely diagnosis? Now see, here the case is complicated. Why the case is complicated? Here you don't have exactly the reason which is based on the cholelithiasis. Here you have the reason where the obstruction occurred because of the stone, impacted stone, and that stone is caused the dilatation of the common bile duct. That stone is actually obstructed the common bile duct. It will cause the distension of the gallbladder. It will cause the bile to remain inside. That's why the total bilirubin level will be increased. But as the pancreas is inflamed, you will see this high levels of amylase. Very high level of amylase is suggestive that pancreatitis is there, but because of the impaction of this stone in the common bile duct, that gives the clue. And what is the clue for this one? Because see, once the cholelithiasis is there and the stones are not obstructing any kind of duct, you will only see the stones are there. Once you do the ultrasound, you can easily find stones in the gallbladder or maybe stones somewhere, but that stones are actually not obstructing any kind of duct, not obstructing the common bile duct. But if a stone is there stuck in the common bile duct, then not only you will see that can cause the distension of the gallbladder, that can cause the increased levels of bilirubin. That's why the patient must be presenting with the jaundice. If the patient is having cholecystitis alone, asymptomatic cholecystitis, the patient must not be having jaundice at that time. Although the stones are there, it has nothing to do with the stones. Stones are there that can irritate the gallbladder, but it has nothing to do with the obstruction, so that the patient bilirubin level will be normal and the patient must not be presenting with the jaundice. But if the stone is going to impact or obstruct it, or is going to obstruct the common bile duct, then you will find the increased level of bilirubin. Then you will find the patient must be presenting with jaundice. Then you will find that infection of the stone is actually the leading cause of this pancreatitis. It's causing the inflammation in the pancreas, because we have already read so many etiologies of pancreatitis. There's not only single, only solitary cholelithiasis. It may be impaction of the obstruction of the stone. It may be tumor of the pancreas itself. It may be some other factors which we have read. There are so many factors that can cause pancreatitis, but mostly we have read only two. Mostly we found usually two. What are they? Number one, alcoholic history, and number two, cholelithiasis, asymptomatic cholelithiasis. But here, the patient's having cholelithiasis, but the stone is actually obstructing the common bile duct. That's why on ultrasound you are finding dilated common bile duct. So here, of course, you will say that based on the increased level of amylase, you will say it's a pancreatitis. Why you're not saying it's hepatitis? Again, you will not find a high level of amylase in there. In cholangitis, there's particularly a gallbladder. It has nothing to do with the pancreas and all that. You will not find any kind of CBD involvement and everything there. Acute cholecystitis, that's only related to the gallbladder. You will not find the whole abdomen is standard. You will not find during examination the whole. And of course, when you do the particular examination, you do the lab testing, it has nothing to do with the amylase level. So it's a clear case of pancreatitis. But remember here, the etiology is the stone which is actually impacted in the common bile duct, causing the distension of the gallbladder, causing the impaction of the bilirubin, high level of bilirubin, causing the jaundice in the patient. Plus, all these factors will lead to pancreatitis.
Excuse me, Dr. Hira, what is
Yes,
cholangitis?
Cholangitis, we usually find the inflammation in the gallbladder, and mostly the small, especially the duct of the gallbladder, you will see that is inflamed because of any reason. But most of the time, you will find stones are the reason, but sometimes there are not the stones, but still you will find inflammation. So you can say it's inflammation of the gallbladder.
No, cholecystitis is also the inflammation, same thing.
Cholecystitis is especially the inflammation of the gallbladder, which is basically due to what? Due to stones in the gallbladder. Yes.
Okay. Okay, cholecystitis infection due to stones, and cholangitis is infection without
and
stones.
mostly in cholangitis, you will find the bile duct system involvement. Like there's an inflammation of the whole bile duct, which is the duct which is coming from the gallbladder. That you will find inflamed. Sometimes the reasons are stone, and sometimes the reasons are viruses. Sometimes the reasons are infection. Sometimes the reason can be any. It's not mainly because of the stones. It can be, the reason can be any, right? But it must be a inflammation of the whole bile duct system. That is cholangitis.
Okay, okay. Doctor, please can you briefly elaborate the difference between indirect and indirect bilirubin, the reasons?
Yes, sure. You want the reasons? You want the
No,
comparison between?
the differentiation between indirect and direct bilirubin. How will you describe if it is indirect?
Yes. See. Uh, you know any idea about unconjugated and conjugated? If you know that idea, that you can easily relate to this one. So say for example, you know the bilirubin, right? So if bilirubin is bound to albumin especially, so we say that that bilirubin is a unconjugated bilirubin, and that is called indirect bilirubin. So bilirubin is actually the thing which is going to produce from the liver. So if it's going to bound with the albumin, we will always say this kind of bilirubin is called the unconjugated bilirubin, or the another name for this one is indirect bilirubin. Right? Now what happened here? Yeah. So sometime what happened? Yeah.
If it is bound with the bilirubin, then it is indirect.
Yes, that is indirect. If it's called, if it's bounded with the albumin, then you can say it's the unconjugated one. Then you will say it's the indirect one, because in the liver, bilirubin is changed into a form that your body can get rid of it. So that bilirubin is actually called the conjugated bilirubin or the direct bilirubin. So just think about this one, that it's not only about the albumin actually, but most of the time we have seen this albumin. Albumin is a carrier protein. So if it's going to bound with the this one bilirubin, we will say it's a conjugated one. Oh, sorry, my bad. Sorry, my bad. It's a reverse thing. If bilirubin is going to bound with the albumin, we will say it's a I've already
Direct one.
You correct?
If it is bound, then it will be direct or conjugated. Now, if not,
let me pull out, because I am saying the right one, but we should have in front of us. Direct billing is indirect billing. Okay. No, I want to see albumin part. Physiology. Okay. See, they are saying some bilirubin is bound to a certain protein, albumin. Again, it's true, albumin. So if bilirubin is going to bound with albumin, this type of bilirubin is called unjugated or indirect bilirubin. So that's a true thing, right? With the first thing which I told you, that if the albumin is going to bound with bilirubin, we will say it's an indirect bilirubin. In the liver, bilirubin is changed into a form that your body can get rid of. This is called conjugated bilirubin or direct bilirubin. This bilirubin travels from the liver to the small intestine, a very small amount passes into your kidney, and blah, blah, blah. Okay, so just only the difference between this direct and indirect, just based on the bounding of with this albumin. So if it's bound with the albumin, you will say it's an unconjugated one, or if it's not bound with this one, we will say it's a conjugated. And why it has to bound with albumin? Just in order to eliminate this one from the body, because if it's not bound, if it's not going to bound with albumin, it's not going to be eliminated from the body. So the whole phenomena of binding this with albumin is to just make sure the excretion of bilirubin should be there in the urine, or should be there in the stool as well. So that is the whole phenomena. You got my point?
So when is albumin is bound, then it's an indirect or
indirect one. And just think this one, that why the bounding should be there, in order to make the elimination process easily, because that's a carrier protein. It will take it easily from the channels, easily from the basement membrane. It can be easily get rid. So that's the whole thing, why it has to be conjugated with albumin, just in order to release it. Otherwise, if it's not going to bound with the albumin, the release phenomena, the elimination phenomena will be difficult one. That's the only reason.
No, it has to separate from the albumin, to be separated, to be released from the body, to become conjugated.
So that's why we are saying now no, it's opposite. You are saying the opposite thing. See, once we say bilirubin, just think about if it's only bilirubin, it's not bounded with anything. We say it's a conjugate one, right? When it's only bilirubin, it's not going to bound with anything, just a single bilirubin. We say it's a direct bilirubin and it's a conjugated one. Its morphology is conjugated.
Yes.
Conjugated is based on morphology, but once it bound with albumin, it will become unconjugated, and when it will become unconjugated, it can easily excrete it. That's the whole phenomenon. Now you got the point. So if it's direct one,
once it is bound, then it can be easily excreted to unbound.
Yeah, no, once it's bound, because albumin is a carrier protein. So it's going to take it and help with the elimination process. So in order to be eliminated, it has to bound with the albumin. That term is known as unconjugation, when it's going to bound with the albumin. And once indirect, it's called indirect. And when it's not bound with anyone, it's called conjugated one or a direct one.
Okay, that bound is unconjugated. Okay.
Yes. Because normally we don't bother, because in clinical practice we are least bothered with this conjugation and conjugation. Only we should see the total bilirubin. So that's why sometimes during clinical practice you're not bothered about this one. Okay, so let's do this one. A 60-year-old woman present with a 12-hour history of severe pain in the epigastrium. Now this patient is having this severe epigastric pain for 12 hours. It is associated with nausea and 2 episodes of vomiting. So nausea, vomiting is there, epigastric pain is there, and this particular radiation, whenever we say epigastric pain radiated to the back, it's always considered to be the pancreatic pain. So that's a very common presentation of pancreatitis. She has a history of cholelithiasis. Again, the same presentation, the stones are there. Abdominal examination confirms generalized tenderness in the abdomen. So it means tenderness is there. Now, which of the following is the most likely diagnosis? So it's very clear, based on the presentation, based on the epigastric pain which is radiating to the back, based on the presentation, nausea, vomiting, and based on the history of cholelithiasis, it's very obvious that this is a case of pancreatitis. If you have the level of amylase, that will give you a definitive diagnosis. If you have the levels of lipase or maybe calcium levels or lactate dehydrogenase level, so you can easily get a clue. But still, based on the presentation and based on the finding, you will say it's acute pancreatitis. Okay, let's go to the next one. Next, we have appendicitis. Again, it's not there in MTB. So let me take you to Ambus.
So, Dr. Hira, in joinders, there will be less conjugation, means there will be less production of albumin and less binding, and there will bilirubin will increase in the body and less elimination from the body.
Yes, true. Exactly. Okay. So for acute appendicitis, see appendix, if appendix is going to inflame, we will say it's acute appendicitis. The presentation is very, very common. Whenever the patient presents to you and he is having, first of all, this periumbilical pain, and then periumbilical pain is going to shift towards the right iliac fossa, that's a clinical presentation. In our routine practices, in our clinical practices, if the patient presents to you having nausea, vomiting, fever is there, and he's having periumbilical pain, and soon after the pain is going to shift into the right iliac fossa, you can easily say it's a appendicitis case. So acute appendicitis is the acute inflammation of the appendix. Normally the appendix, in our case, appendix is of course vestigial organ, because we don't have any kind of cellulase enzyme in the appendix. But in all the herbivorous animals, their appendix are usually working very fine. Why? Because they have cellulase enzyme in the appendix, and that is actually doing the phenomena of digestion. But in our body, we don't have cellulase in the appendix. So for us, appendix is vestigial one. But if the fecal impaction is going to be, if the this fecal material is going to be impacted in the appendix, it can cause appendicitis. So it is the most common cause of acute abdomen requiring emergency surgical intervention. Of course, in children and adults, most commonly the children are presented with this one. The characteristic features of acute appendicitis are periumbilical. First of all, the pain is periumbilical, and then it's going to shift towards right iliac fossa. Fever must be there, and this right lower quadrant tenderness must be there. When you check the WBC count, you will see neutrophil leukocytosis, WC must be raised. There are features to make a clinical diagnosis of appendicitis. So based on the clinical features, we usually go for the diagnosis. But still, for the diagnostic point of view, we can go for the abdominal CT. And please remember, in the case of appendix, ultrasound will not, although ultrasound we can do, but ultrasound will not be a good choice. You always have to go for CT fast. CT fast, abdominal CT. We will always consider abdominal CT in order to make a diagnosis of appendicitis. So we should not waste time in doing the ultrasound and all that. If you are clinically suspicious, if you see the clinical symptoms are quite suggestive, then always go for CT scan. So maybe consider, now the current standard of management of acute appendicitis, of course, if it's an emergency, you have to go for appendectomy. So laparoscopic choice are the gold standard nowadays. We should not go for open laparotomy. We should always go for laparoscopy. Non-operative management, which include bowel rest and antibiotic, it depends if there is not too much, symptoms in the body. If there is appendiceal abscess on CT scan, you will not find too much inflammation, too much infection, too much necrosis is not there. Then maybe you can think about some conservative treatment, but it's always a good choice to go for appendectomy. So if we have a look here, clinical features, how our patient is going to present. So migrating abdominal pain, this we have already done this one. The typical presentation is periumbilical, and then it's going to localize towards right lower quadrant. Nausea, vomiting, anorexia must be there. Diarrhea, constipation history can be there. Clinical signs of appendicitis, that is a very important thing. We will see during examination McBurney point tenderness. And what is this McBurney's point tenderness? Tenderness at the junction of lateral third and medial two-third of a line joined from the right anterior superior iliac spine to the umbilicus. So you just imagine the patient anterior superior iliac spine, and in between the anterior superior iliac spine and the umbilicus, if in the lateral third and medial two-third, if you just put your finger and you will find tenderness. You will just look at the patient or patient face. If the patient is feeling pain while touching this area in between this anterior superior iliac spine and umbilicus, you will say that's a McBurney's point tenderness. And if the patient is in pain because of your examination, you will confirm that this patient, and how the patient is showing, the patient's face must be ill. The patient will show that he is having pain. Plus, you will find the guarding also. There will be tenderness here and rigidity here in this area. So that will give you a clue. Sometimes we will found this Rossing sign and Saw sign as well. These are again the supportive sign. Rossing sign means that Rossing sign means that right lower quadrant pain elicited on deep palpation. When you just palpate deep, the patient must be having pain. So that is called Rossing sign. Soft sign can be performed in two different ways. Can be elicited on flexing the right hip with a stretched leg against resistance. So you will just flex the right hip, you will just flex it, and then you will stretch the leg. And by doing this maneuver, if the patient is experiencing pain, that is called soft sign. What you will do, you will just flex the right hip, because the right side we are going to confirm this one. So you will ask the patient to flex the right hip and you just stretch the leg straight. And if the patient is experiencing pain, that is called a soft sign. But anyhow, if McBurney's is there, so these patient must be in so much pain that these signs sometimes with the patient, without these signs, the patient is showing so much pain. So it's not a thing. But of course, by doing this thing, if the patient's pain exaggerated and the patient is feeling more pain, then we can. But it's an always ideal thing not to give too much pain to the patient. So we should always avoid these signs. If on McBurney's you are not going to get anything, then only you can go for this Rossing sign and soft signs. But of course, if you have already this positive McBurney sign, you should not go for the other supportive signs. These are just the supportive signs. If there is not too much inflammation or infection and the patient is not experiencing too much pain, it's slight pain is there. So just in order to confirm, you can go for these signs. Obturator sign also, this right low quadrant pain or passive internal rotation of the right hip with the hip and knee flex. So hip is also flexed, knee is also flexed, and once you do the internal rotation, the patient is experiencing pain. But if the patient is already in too much pain, you should never go for all these signs. These signs are just the supportive signs whenever there is infection, inflammation, but the patient is not very much symptomatic. Then only you can initiate these signs just in order to make a confirmed diagnosis. Okay, so for the diagnostic is always a clinical diagnosis, but lab test of course will give you a clue. You will see increased leukocytosis, especially neutrophils will be high. You will see the CRP level. ESR and CRP will always be high whenever there is an infection or inflammation. You will check this BMP. BMP is basal metabolic panel, where you do the all the this thing, like you will do the electrolytes, sodium, potassium, chloride, bicarb. You will check these electrolytes. So they are saying this BMP will show increased creatinine, electrolyte abnormalities may be present. If there is too much vomiting, of course we know very well, if there is too much vomiting, the patient is going to have decrease in potassium. So electrolyte will be disbalanced whenever there is too much vomiting. So you can find changes in the electrolyte as well. Diarrhea is there. Of course, in diarrhea, the patient is going to lose electrolytes. Urinalysis you will do. Sometime in appendicitis, possible findings of mild pyuria and hematuria. Of course, infection is there. So you can find pus also in urine sometime, or sometime hematuria, but they are not very much suggestive. Of course, whenever the patient comes to you with this one, if it's a female patient, you can always think about ovarian torsion. You can always think about ectopic pregnancy. So you have to rule out those, especially in order to, if there is ectopic pregnancy, you go for the beta HCG. If beta HCG is positive, you will get a clue. If it's ovarian torsion, once you do the CT scan, it will be visible on the CT scan, but must keep a DD in your mind. So these are the some symptoms again. So anorexia, nausea, vomiting, pain must be there. Lab test, you have to go for leukocytosis. You will see. So these are some criteria. These are some scoring system that's called Alvarado scoring. And by this scoring system, if the score is less than 4 or 4, we will say the likelihood of appendicitis is low. But if it's 5 to 6 scores, so you just count the numbers. If anorexia is there, 1 point. If pain is there, periumbilical, and then shifting to the right lower quadrant, you will give 1 point. If there is tenderness in the right lower quadrant, 1 point, 2 point. Rebound pain is there, temperature is there. So these are all the points. So it's not necessary, because once the patient is there in the emergency department, it must be with the symptomatic complaint. Whenever the patient is asymptomatic, it will never come to you, and you will never get an idea. Of course, if the patient is landing up in the emergency department, it must be having all these things, and you will always find 7 and more than 7. That's why you will go for emergency appendectomy. Pediatric was not concerned about this one. So imaging, we have already confirmed this CT abdomen with IV contrast. Please always remember, for your exam point of view, that this is the preferred initial imaging modality you should always go for. We should never go for ultrasound. If this clinical suspicion is high, you have the clinical presentation is too much suggestive, directly go for CT abdomen with IV contrast. That is sometimes called fast CT scan. And that will give you a clue whether it's appendix inflamed or not. Diagnostic laparoscopy will be the option for appendectomy. Always go for the laparoscopy. These days, we'll prefer laparoscopy. We'll never prefer laparotomy. Before that, we will usually perform laparotomy, but nowadays, laparoscopy, with the help of laparoscope, you can easily remove this one. And of course, there will be there are much more advantages doing this laparoscopy, like less scar will be there, less complications will be there, and everything. For the treatment point of view, supportive care, bowel rest, you are not going to allow patient to eat anything. You will provide IV fluid. You will just correct the electrolyte imbalance. You will give painkillers. You will give antiemetics. You will give antipyretic if fever is there. Of course, we will give antibiotics. Antibiotics with all acute appendicitis cases, of course. And if it's a ruptured appendix, then you have to give antibiotic for a longer period of time, gram-negative cover as well. So that is again the complication one. If the appendix is going to get ruptured, you have to put your patient for a long-term management of antibiotic regimes. So if it's an uncomplicated appendix, we can give these medications for 24 hours only, especially cephalosporin. You can give, or combination therapy with first generation cephalosporin. You can give in patients with metronidazole. So metronidazole for gram-negative cover, and first generation cephalosporin. That should be your ideal choice if the patient is having uncomplicated appendix, like there is no rupture and all that. But if there is a complicated one, so you have to go for more than 3 to 5 days. Treatment should be up to maybe sometime till 7 days, or maybe sometime till 3 to 5 days. But if it's uncomplicated one, 24 hours antibiotic is enough. But if it's a complicated one, like rupture is there, you have to go for 7 days. So just have a look at the question here. Now the question says, a 27-year-old obese woman present to the emergency department with a 6-day history of right iliac fossa pain associated with nausea, vomiting. Now she's having a history for 6 days. Right iliac fossa pain is there. She's 27. She's obese. Now, and loss of appetite is there. Physical examination confirmed tenderness in the right iliac fossa. So right iliac fossa confirmed on examination that there is a tenderness. So whenever the right iliac fossa is there, but of course she is 27 years old, she's fertile. You should always exclude the ectopic pregnancy as well. WBC is raised. WBC is high, infection element is there. Which of the following is the most appropriate next step in management? So, of course, in order to rule out ectopic pregnancy as well, you have to go for beta HCG. There is no beta HCG in here, leave it. What we can do, we can go for CT scan, because we know very well CT scan is highly suggestive if the clinical suspicious is high. So the clinical suspicious and on CT scan again, if there is ectopic, if there is ovarian torsion, you can always figure it out on CT scan, especially not the topic of one, of course, but torsion, ovarian torsion, you can easily appreciate on CT scan. So here we'll go for abdominal CT scan. That is highly suggestive for in order to rule out appendicitis. And not only appendicitis,
Dr. Hira,
the other DTs also. Yes, dear.
when we have confirmed our abdominal CT, then what is the need for diagnostic laparoscopy?
What will be the need of what?
If we have
Huh.
if we have confirmed on abdominal CT, then what is the need for diagnostic laparoscopy?
Diagnostic laparoscopy, no dear, it should be a therapeutic laparoscopy. During laparoscopy, you will remove the appendix. The appendix which is inflamed, you will remove through laparoscopy. So that is not the diagnostic laparoscopy. That's a therapeutic laparoscopy. Laparoscopy is the gold standard for appendix, gold standard for gallbladder removal.
Okay.
We do the diagnostic laparoscopy once we cannot find or we cannot rule out what the pathology is there inside. But usually on CT scan, we usually confirm this one. So nowadays, it's very rare we go for diagnostic laparoscopy. We will always for therapeutic laparoscopy. So we don't say diagnostic and therapeutic, we just say laparoscopy.
Before we were doing the treatment of appendix there, we were seeing the diagnostic laparoscopy. I was surprised why to do a diagnostic laparoscopy.
No. Diagnostic in the sense that maybe on opening and by seeing you will find that okay, appendix is not too much inflamed. There may be peritonitis, that was the reason. So you will leave it like that. Then in that case you can say diagnostic. But of course, it's not like that. Once you have these lab investigations with you, once you have the CT scan, confirmed CT scan, if on CT scan you can easily appreciate the mucosal thickening or mucosal inflammation of the appendix, then it's very less likely that upon opening you will find no appendix inflammation. Most of the time it is there.
Okay.
But sometimes it can happen. You open you do the laparoscopy and you don't find anything. Then you will just, in your notes, you have to mention diagnostic and you cannot mention therapeutic one in that case because you didn't do anything. You didn't pull out anything. You didn't remove anything.
Okay.
For this one, we have to go for the theory first. Next, we have femoral hernia. Femoral hernia again is not there in MTP, so I should take you here. The femoral hernia and inguinal hernia questions are very common. Here, especially if you are considering femoral hernia, you should know the boundaries of the femoral canal, and especially for exam point of view, we are not here bothered about the boundaries, like who is going to form which boundary. But of course, those who are preparing for hard, they should know. Those who are preparing for USMLE step 1, they should know each and every anatomical variant of everything. But for our DHA point of view, for our MOH point of view, they don't bother with, because it's all clinical knowledge-based testing. So they are not considered about the making of boundaries and who is responsible in there. But landmark, you should know. Say, for example, inguinal ligament, if it's a landmark. So whenever, say, for example, whenever during clinical practice, when we have this strangulated hernia, and upon seeing we exactly cannot find what kind of hernia is this one, then we should know the anatomical landmarks. Say, for example, if a strangulated hernia is there, and during the surgery, if the surgeon can find that below the inguinal ligament there is a strangulation, they usually say it's a femoral hernia. If above the inguinal ligament there is a strangulation, they usually say it's an inguinal hernia. So at that point, of course, anatomical variation should be very important, and we should know that sometime when there is a strangulation and we cannot easily correlate whether it's a femoral hernia or it's inguinal hernia. So we should know the important landmark, that is inguinal ligament or pubic tubercle. You should know where it is, and whoever the hernia, which is a strangulated one, if the neck is above the inguinal ligament, that must be an inguinal hernia. If it's below the inguinal ligament, that must be a femoral hernia. So I'm just saying you that you should emphasize much on this clinical aspect as far as your DHLMOH is concerned, but you should not worry about that which is going to form the which boundary of the triangular canal. So here we have, although you can just go through it, boundaries of the femoral canal: anterior is inguinal ligament, posterior is pectineal ligament, and medially there's a lacunar ligament.
Dr. Hira, let's see the diagram.
Yeah.
Let's see the diagram.
Yeah, we will see. Typical femoral hernia, common protrusion of intraperitoneal content along with the, see, whenever we say hernia, it means that from the opening there must be something coming. So if there is a protrusion of intraperitoneal content, whatever is inside the peritoneum, if that portion is coming out along with the transverse abdominal fascia through the femoral ring into the femoral canal, we can say it's a hernia. So simple is that. In simple words, we will just remember that whatever the content of the stomach or whatever the intraperitoneal content is there, if they are coming out into the femoral ring, into the femoral canal, we will say it's a femoral hernia. That's a typical femoral hernia. So let's have a look here, which you want to see. Now, if you say the boundaries, so we have this lacunar, this femoral ring, if we are considering this one, lacunar ligament is here. Where is femoral inguinal ligament? Inguinal ligament is here, lacunar ligament is here. Only this portion, femoral canal, this portion is, you will find. Just go back to the theory. Anterior, we have, for femoral canal, they are actually giving you the boundaries: inguinal ligament, posterior pectineal ligament, and medial lacunar ligament. So we'll show it again here. So this is the femoral canal, and femoral canal is formed here. Femoral canal is formed. Lacunar ligament is where? Lacunar ligament is medially. So if we can see here, lacunar ligament, of course, if it must be, the pubic symphysis must be here. If the pubic symphysis must be here, so whatever the thing is here, it's considered to be the medial one. Whatever the thing is considered to be the lateral one, that is the superior one, and that is the inferior one. So we say lacunar ligament medially. So this is lacunar ligament, and it's medially towards the pubic symphysis. This is lacunar ligament, this is medially, right? And we say inguinal ligament anteriorly. This is the inguinal ligament, the big one. So it's inguinal ligament, it's anteriorly. And what is the third one? Pectineal ligament posteriorly. Where is the pectineal ligament? It should be on the pectineal line. It must be here somewhere. It's mentioned here or not? It's not mentioned here. Pectineal ligament, and what the other thing? Posteriorly in the fibrous sheet of the femoral vein laterally. Let's see the femoral vein here. This is the femoral artery, femoral vein. So femoral vein should come laterally. Of course, this side is lateral, this side is medial. So pectineal ligament must be here somewhere on the pectineal line. It's not labeled here, but pectineal ligament should be here because pectineal ligament is posteriorly. Whatever the thing which is anteriorly is the inguinal ligament, and posteriorly is the pectineal ligament. Medially, we will find this one, lacunar ligament, and laterally is the femoral vein. So this is the femoral ring, this is the femoral canal. So if the abdominal content is protruding and coming out from this area, you will say it's a hernia. It's a femoral hernia. And for our strangulation point of view, which I really emphasize on based on the question, based on the recall. So just remember, whatever the content who is coming below the inguinal ligament, it should be a femoral hernia. But if it's above the inguinal ligament, it must be a inguinal hernia. I will show you this one later. So let's go back to the theory again. So boundaries, again, you can go over it, but we are more concerned about the clinical features here. So if it's a non-complicated femoral hernia, whenever we say complicated and non-complicated, complicated means only two. Whenever we are reading hernia and we say complicated hernia, we should always consider two things: whether there is any incarceration or incarcerated one, or maybe a strangulated one. So whenever we say incarcerated or strangulated, it means we are referring to complicated hernia. And whenever we say non-complicated, it means that there is no strangulation here and still the hernia is reducible one. It doesn't go into the state of irreducible one. So A femoral hernia, of course, is a preliminary clinical diagnosis. You do the groin ultrasound, if that is not going to be very much conclusive here. And femoral hernia can be difficult to palpate in obese patient. Ultrasound is indicated if femoral hernia is suspected in the patient group. Although it's there, if the swelling is there, so the clinical presentation is swelling. If the patient is complaining of any swelling in the groin region, you can always think about femoral hernia. And femoral hernia and inguinal hernia only on the basis of anatomical variation, you can say whether it's an inguinal hernia or it's a femoral hernia. Only on examination you will confirm, or maybe during surgery when you exactly see the boundaries and all that. Other than that, you cannot say. On the basis of physical, on the basis of clinical examination, on the basis of clinical symptoms, you cannot say it's a femoral or inguinal hernia until and unless you see the anatomic variations. So complication always incarceration and strangulation. So of course, whenever there is strangulation, you know very well, if the strangulation is there in the whole intestine, when we are considering small or large intestine, the total lifetime period is 6 hours. If we can go beyond 6 hours, that area can be completely necrosed and the cell death can occur and the patient may die because of this one. So whenever there is strangulation, that is always considered to be a emergency. You have to go for emergency surgical resection of that thing. There is one more thing I want to show you here. This one, because a recall will be here, so I cannot find in the amber, so I just searched this one. A hernia in the groin area above the inguinal ligament. So it's actually for the surgeons when they are doing surgery, how they and if especially the strangulation is there, then how they can say that it is an inguinal hernia, strangulated inguinal hernia, or strangulated femoral hernia, because position is almost the same. So they usually have this inguinal ligament as the anatomical landmark. If the hernia in the groin area above the inguinal ligament, they will always consider this as inguinal hernia. So whoever hernia whose strangulated neck is above the inguinal ligament, you will always say it's an inguinal hernia. And if it's below the inguinal ligament, you will say it's a femoral hernia. That is a helpful condition, helpful key point for surgeons when they are doing surgery. And once they find out that this is a strangulated hernia, and in order to make a diagnosis whether it's because once there is strangulation, you cannot find the proper anatomy. Then only the landmark is inguinal ligament. So if hernia neck is coming from above the inguinal hernia, above the inguinal ligament, you will say it's an inguinal hernia. And once the neck of the strangulated hernia is coming below the inguinal ligament, you will say it's a femoral hernia. That's a surgical help for the surgeon. So coming back to the question.
Dr. Hira?
Yes, dear.
Inguinal ligament is an insertion of which muscle?
Ligaments, not an insertion of muscle. It's a ligament. I will show you. Yeah.
Okay, tendons are the insertion.
Yeah, tendon is the part of the muscle
around the joints,
around the bones to bones. Ligaments are always bones to bone, and like say for example, there's a pubic bone and there's a anterior superior iliac spine. So the ligament which is coming from the anterior superior iliac spine to the pubic tubercle, that is called inguinal ligament. And this is actually the one which is going to separate the lower abdomen to the thigh. That's the anatomical landmark. So whatever the hernia whose strangulated neck is coming down, the surgeon will say it's a femoral one. Up, the surgeon will say it's a inguinal one. This is the one, inguinal ligament, coming from the anterior superior iliac spine to pubic tubercle. So let's have a look at the questions. Here the question says, a 48-year-old woman presented with a 12-hour history of painful swelling in the right groin. So she is 48 years old and she has a history of 12 hours history of painful swelling. Swelling is there in the right groin. So whenever it says swelling, you should always consider about hernia. Physical examination confirmed and irreducible tender swelling in the groin area. So that's a irreducible tender swelling. Like the surgeon cannot reduce it. The doctor cannot reduce the swelling. Normally, if there is an inguinal hernia, which is very much common in males, of course, it's not very common in female, but it can be there. So that can easily be reducible. But again, if it's a strangulated one or incarcerated, you cannot find this reducible power. Surgical exploration confirmed a strangulated hernia. Now, once they have already started this surgery and they explored it and they found out that this is a strangulated hernia and the neck is lateral and inferior to the pubic tubercle, that is below the inguinal ligament. Now, what you will think? Which of the following is the most likely hernia? So, whoever the hernia who is
Femoral.
below, yeah, that's a femoral. If it says above the inguinal ligament, you will always think about inguinal hernia. The next one we have to go for the theory. Next we have this parathyroid adenoma. Again, it's not there in MTB. Let me take you to Ambas. So, and by the way, it's not there in Ambas also. So I have to take you somewhere. Say, for example, I have found this good site here, which from where we can easily find this parathyroid adenoma. So parathyroid, these are the 4 small endocrine glands located just in front of the thyroid. They will say it's a parathyroid glands, and these small 4 pea-sized glands, if you are going to see that there is some tumor activity in those glands, mostly all of them are not going to involve. You will see only 1, maybe 2, or maybe 3. All 4 will never ever go into the tumor or at all, like together simultaneously. You will not find any tumor activity in all the 4 glands. Most of the time it's only the 1 gland who's having this tumor. So think about whenever this parathyroid gland tumor activity is there only in the 1 gland, so you will say it's a parathyroid adenoma. And mostly parathyroid adenoma ended up into primary hyperparathyroidism. What is primary hyperparathyroidism? In which the parathyroid gland is too much functional, it's going to secrete. What is the function of the parathyroid gland? Parathyroid gland is actually secreting parathyroid hormone, right? So if there is adenoma, to think about, if there is adenoma, there is too much cell, then what will happen? There will be too much amount of parathyroid hormone release. And if this parathyroid hormone is released, what will happen? Parathyroid hormone has to function, like it has to, the main function of parathyroid hormone is to retain the calcium in the blood so that, the calcium can perform its activity. So that is the main function of parathyroid hormone. So what is happening here in this parathyroid adenoma? Always remember, parathyroid adenoma, there is tumor activity in the parathyroid cells, and parathyroid cell will release more amount of parathyroid hormone. That's why mostly in all patients, the one who is having parathyroid adenoma will always have primary hyperparathyroidism. Primary hyperparathyroidism means that when you check the level of parathyroid hormone, you will find increased amount of parathyroid hormone, and when you check the amount of calcium, you will find increased amount of calcium. Why increased amount of calcium? Because that's the function of PTH. PTH function is to increase the amount of calcium. No doubt it has to take calcium from the bones. Sometime when calcium is deficient, this PTH is so harsh that it has to take calcium. Its function is to maintain the level of calcium in the body. No matter, it has to take calcium from the bones. So it start stimulating osteoclast cells. Osteoclast cells are the cells which are actually responsible to do the lysis of the bones. And bones, once the bones is going to get lysed, think about the bone full of calcium. So you will get more and more calcium once the osteoclast cells are active, and they act on the bone and they will do the lysis of the bone. So you will have so much calcium. So that's the function of PTH. PTH is so much concerned about maintaining the level of calcium that it does not, bother about to releasing the calcium from the bone. It stimulates the osteoclast cells, it will do the lysis of the bones, and it will maintain the calcium amount in the blood. So that's the main function of parathyroid. So always remember, parathyroid adenoma can lead to primary hyperparathyroidism. Now here it's saying what is parathyroid adenoma? Sometimes benign, of course, most of the time they are benign, but of course can be malignant as well. So appear on 1 or more percent parathyroid gland. The cause of most parathyroid adenoma is unknown. We don't know. It's idiopathic. However, about 10% are thought to be hereditary. Radiation exposure of the head and neck may also increase the risk of adenoma. So if there is any history of radiation exposure, those patients can present with this one. Adenomas cause the parathyroid gland to make more parathyroid hormone, and then you can think about if there is more parathyroid hormone, then it can lead to primary hyperparathyroidism. So how you're going to diagnose these patients, how they're going to present. Sometimes they are presenting with the stones because there is too much calcium in the blood. If there is too much calcium in the blood, that calcium can form stones in the kidney. So the patient can present with the kidney stones because bone and joint pain, because calcium is releasing from the bone because of the PTH. Some kind of abdominal pain is there. So just think about the etiology. So hypercalcemia, what they can do. So you can put all those symptoms here. So bone pain is the most common presentation, confusion, hoarseness, neck mass that can be felt with the hand. Of course, if there is tumor in the parathyroid gland, you will always find neck masses. Once you do the examination, you can easily see this one. Now, there's some diagram here, I think. No, I missed that one. Okay, so do I need surgery? Of course, that if whoever the parathyroid gland is having tumor, your main treatment will be to do the parathyroidectomy. You will remove that tumor, and mostly it's only one gland, so it will be very easy to remove. Other than that, if the 4 glands are involved, it's okay. You will go and get the removal of all four glands. So we'll go for the ultrasound of the neck first, and then we can go for the CT and MRI to confirm the diagnosis. Okay, so let's have a look at the question. Here the question says, a 32-year-old man previously diagnosed case of parathyroid adenoma. So now you have the diagnosis with you. He is already a known case of parathyroid adenoma. Presented to the emergency department with pain and swelling of his right thigh after triple injury. So some injury has happened and he is now presenting to you having his right thigh inflammation. On physical examination, confirmed swelling and deformity of his right thigh with tenderness. So you can think about this deformity, maybe a fracture is there. And why the bone is, see, he's so young, he's 32 years old, and in case of emergency, if it's a heavy road traffic accident or motor vehicle accident, you may think about the fracture. But most of the time, in young person, if this femoral, which is a very big bone, considered to be the biggest bone in the body, is getting fractured, so there must be some pathology behind, and already the pathology is parathyroid adenoma. So what must be there in this patient? Because of the parathyroid adenoma, the patient's parathyroid hormone is very high, and this PTH is actually doing what? Is actually removing the calcium from the femur and thereby causing the deformity in the femur. That's why by just having the accident, this patient is presenting with deformed femur. The femur is deformed, who's the strongest bone in the body. So think about this one. Now test results showed parathyroid hormones, of course, high, 8.9. So it will also give you a clue. Parathyroidism is there. Calcium is high, again will give you a clue. So parathyroid hormone, because of the increased amount of parathyroid hormone, because of the increased amount of calcium, you will always think about that this patient is actually presenting with features of hyperparathyroidism. And he's already a known case of parathyroid adenoma. So it's clear clue that parathyroid adenoma mostly present with primary hyperparathyroidism. And if there is primary hyperparathyroidism, you will see on X-ray what? Spiral fracture. Of course, fracture is there because of the accident, because of the injury. But with subperiosteal resorption, it's mentioned subperiosteal resorption. What you can see here, if it's a fracture, it's a fracture. The bone should be normal. The bone morphology and the bone histopathology should be normal. If it's just a fracture, because it's an injury. But if it's showing subperiosteal resorption, it means that the bone is actually getting lysed. Osteoclastic activity is so much high that the bony matrix is very low in quantity. And why is that so? It's all because of PTH, because PTH function is to maintain the calcium in the blood. No doubt he has to maintain the blood, and what he can do, he can just do the lysis of the bone. That's why it's mentioned here subperiosteal resorption. Otherwise, if it's just an accident, it should only show spiral fracture of the femur. The femur anatomy should be normal. The femur histopathology, the bone matrix should be a normal thing. But because of the adenoma, with the passage of time, the parathyroid hormone is actually acting on the bone and causing the lysis of the bone. That's why we are seeing subperiosteal resorption. So which of the following is the most likely presentation? Now tell me the presentation. This parathyroid adenoma is likely to present with always ended up in primary hyperparathyroidism. So that's a clear feature of primary hyperparathyroidism. With the passage of time, this PTH is acting on the bone and causing the lysis of the bone and causing the, damage the bony matrix. That's why
So, Dr. Hira?
Yes.
So hyperparathyroidism will cause hypercalcemia.
Yes,
In the blood, calcium level will be high in the blood, but calcium will be mobilized from the bones. The bones will be weak.
See, this calcium is actually released from the bones because of the
Yes.
PTH. That's why you are
There's
having
not deposition in the bones.
yeah.
There's decrease in the bones, and bones are becoming weak.
Yes, that's true. That's why just having a fracture, trivial injury. Trivial injury means that it's not a very much motor, very much traffic accident. It's just a minor injury maybe, and that can lead to a fracture and deformity. That's a very obvious thing that this patient must be having, and he's a diagnosed. If they have not mentioned this parathyroid adenoma, then you have to think logically that why is that so, and then you have to come up with the idea. Okay, parathyroid adenoma, so that the presentation must be primary hyperparathyroidism. But they have clearly mentioned parathyroid adenoma, so your job is easy. But still, if parathyroid adenoma is not mentioned, you can still think, because that's the main thing. Because of parathyroid adenoma, they usually present with primary hyperparathyroidism, and long-standing primary hyperparathyroidism can lead to the lysis of the bones in long term, and the bones will become weaker and weaker. Yeah.
Yes, thank you.
Okay, now for this one, we'll go for the theory first. It's a small portion we can cover quickly. Mallory-Weiss syndrome. So Mallory-Weiss syndrome, I will take you to MTB 732. Okay, Mallory-Weiss, actually it's a tear. It's a mucosal tear in the esophagus. It's not a perforation. If it's a clear perforation end to end, you will say it's a Boer-Haave syndrome. But whenever there is only a tear, why there is a tear? Suddenly the patient started coughing. Coughing is very much intense. It can lead to esophageal tear, but it's just a tear. It's not a perforation at all. So in Mallory-Weiss, you will see vomiting or retching in alcoholics. Alcoholics, they usually retch a lot. So they can just, develop this tear in the esophagus. But if it's too much perforation, we'll say it's a Boer-Haave syndrome. Symptoms, the patient may present with hematemesis. They will say that they cough and the blood is there. But that blood is not coming from the lungs. That blood is coming from the esophageal tear. Dinophagia, difficulty in swallowing food. Location, gastroesophageal junction. So where gastroesophageal junction, where the duodenum is entering into where the esophagus is entering into the this diaphragm, it's crossing the diaphragm, and now it's becoming the stomach. So that thing is called gastroesophageal junction. Once it's crossed the diaphragm, so there you can easily see. There usually you can find a tear. So diagnosis, of course, you will go for the gastrographin follow-up. When you do the gastrographin follow-through, you will see there will be no leakage. But of course, esophagogram, where the tear is there, you will find the most collection of gastrographin there, so that you can have a clue that, okay, this part of the esophagus is actually damaged. The tear is there, but if there is a clear-cut perforation, then what will happen? Gastrographin will leak through that area and come into the other interstitial spaces, so that you can say, okay, that's a clear cut leakage. So if there is no leakage, you will say there is no perforation. It's just a tear. So Mallory-Weiss is just a tear. Boer-Haave is the through and through penetration of the esophagus. So here, of course, whatever the tear is there, you can cautery that area. You can just, cauterize that area. So supportive therapy and cauterization if necessary. And of course, it will not, it will not end up in any kind of complication, because just a tear, it will hone it. It will heal its own. But of course, esophagus has to work a lot the whole time. Every 3 times a day, 4 times a day, we are eating. So esophagus has to do a lot of work. So we can say that the patient has to be on rest. Patient has to go on supportive therapy, because if the esophagus having a tear and it's doing its function, the tear can be prolonged, and then that tear can be converted into perforation. So we have to be very vigilant about this one. We have to give a supportive care to the patient, and we can cautery that area. If the tear is big enough, we can cautery that. So here the question says, a 47-year-old man reported frequent vomiting over the past 24 hours. Now, too much history of vomiting, like 4, 5, 6 episodes at once in 24 hours due to food poisoning. So you can imagine the food poisoning is there, the patient is going to vomit a lot. He presented to the emergency department complaining of 2-hour history of vomiting fresh blood. So this fresh blood is now coming into the vomiting. The physical examination confirmed mild epigastric tenderness. It is not too much, but there is mild epigastric tenderness. A nasogastric tube was inserted and was draining blood stained fluid. So why we have entered this nasogastric? Just in order to make sure that this blood is coming from the esophageal side. That's why we have put this NG tube, and NG tube is a stained fluid, bloody fluid. It means that this blood is actually coming from the esophagus. So which of the following is the most likely diagnosis? Do you think it's a gastritis? If it's a gastritis, there should not be a history of food poisoning and vomiting, because food poisoning must be a sudden thing and vomiting must be a sudden vomiting in this case. So it's not the case of gastritis. Gastritis is a long-standing thing because of the use of too much use of NSAIDs, or if there is a history of too much acidity, that can lead to gastritis. Then this Delphi lesion, I will just explain you later, just now. Now, think about this peptic ulcer. So how we can differentiate that this is not a case of peptic ulcer? Anyone? Dr. Tari? Dr. Tyra? How we can relate it's not a peptic ulcer?
Ulcer will not be acute presentation.
Of course, there must be a history of regurgitation or heartburning or epigastric pain, and that must, peptic ulcer can bleed as well, but that should be a perforated peptic ulcer, and it will present with it's not going to present in such a way that food poisoning is there and all that. It will present in such a way that the patient must be having severe tenderness, epigastric tenderness, and severe vomiting is there, and there's a prolonged history of regurgitation, long-standing GERD, gastroesophageal reflux symptoms are there, then you can say it's a peptic ulcer. And why it's not this delphoid lesion? Because in this lesion, there's a abnormally large artery, a vessel that takes blood from the heart to other areas of the body. So of course, if there is too much abnormally large artery, this is not about artery. It's about esophageal tear, the tear in the esophagus that lead to damage to those arteries which are surrounding that area, and that can lead to. But it's not a biggest artery. Otherwise, you will see like something happened to the aorta. So what you will see, there must be a pulsatile mass, there must be too much hypotension, then the BP should be mentioned, the pulse will be very high. That will show you some internal bleeding signs. Or the patient may present with shock or may present with septicemia.
But they will not be vomiting in the blood, the vomiters.
Of course, there will be a clear cut bleeding history. That bleeding can be in the form of melena or can be in the form of hematemesis. But most likely, if it's hematemesis, that's the upper thing. Upper means esophageal. Yeah. But if the bleeding is like stomach bleeding or duodenum or ileum, that usually present with melena thing. Like you will find blood in the stool, not through vomiting. Yes. So that's a clear case of Mallory White, because he suddenly have a history of food poisoning, vomiting episodes, too much vomiting episodes are there, and that will lead to tear. And with that tear, of course, you can find. If there is the option of Boer half syndrome is there as well. Yeah.
Excuse me, this sudden 24 hours history of vomiting and food poisoning, it will lead to Mallory history.
Yeah, that is the main reason, because in Mallory White state, there's a sudden tear in the esophagus. So the history must be vomiting, sudden vomiting, and that vomiting and retching can lead to tear. It can also happen in alcoholics also, but those alcoholics.
What is retching?
Huh?
What is retching?
Vacuum what?
No, retching.
Retching, like they have a habit of clearing throat. Or maybe, they produce a long sound in just in order to clear the airway. The alcoholics especially, so they usually clear their throat. They are producing harsh sound, voluntary harsh sound with the help of this.
But why are they doing like that?
They just want to clear their throat, because with this alcohol intake will lead to what? It can lead to especially not only the ciliary dysfunction you will find in alcoholics, but the reaction is there with the mucosa of the esophagus. That can irritate the mucosa of esophagus, and that can lead to irritation. And in order to avoid that irritation, they usually do this thing.
Okay.
Yeah. All right, so that's all for today. Thank you so much, everyone, for joining. See you tomorrow. So tomorrow, inshallah, in morning we will cover that, because tomorrow is Friday, so we'll do our session tomorrow. Okay, thank you, everyone. Thank you.
Thank you.